Now we'll start with the renal system. First, let us start with the anatomy and physiology of nephron, then we'll see all the diuretics that are needed for the exam. Okay. So, looking at here, what are the parts of nephron? You can see this part, this is Bowman's capsule, then there are tuft of capillaries, this is glomerulus, then there are tubules. There are folds that are convolutions, so they are known as convoluted tubules. This is proximal, so you call it proximal convoluted tubule. Here you have a distal convoluted tubule as well. In between both of these, you have a loop. This loop is known as loop of Henle. Why? Because the scientist's name is Henle. He is the one who has given this loop. So this is known as loop of Henle. Then finally we have collecting duct. So these are the parts. That's all. So what are the parts? That is glomerulus, Bowman's capsule, proximal convoluted tubule, loop of Henle, then distal convoluted tubule which opens into the collecting duct, and from the collecting duct the urine is coming out. So this is what is basically happening in the nephron. Now whatever is filtered from the blood, it goes into these tubules and most of the filtrate is reabsorbed. Most of it is reabsorbed. When it comes to sodium, almost 99% of sodium is reabsorbed. How? I'll tell you. See, in the PCT, we have an antiporter that is known as sodium hydrogen antiporter. In this, the sodium is reabsorbed and H plus is going outside. So here this absorbs 67% of sodium. This absorbs 67% of sodium. Now coming into the loop of Henle, we have a descending part, that means it is going down, and then there is an ascending part. In the ascending part, we have both thin and thick. So this is thick ascending loop of Henle. In the thick ascending loop of Henle, we have sodium potassium 2 chloride channel. Sodium potassium 2 chloride channel. It will reabsorb sodium, potassium and chloride as well. In here, 25% of sodium is reabsorbed. Now in the DCT, we have a channel that is known as sodium chloride symporter. So in here, sodium is being reabsorbed. How much? Around 5%. Now 1 to 2% of sodium will be reabsorbed in the collecting duct. Now this is cortex, this is medulla. So we call the upper part cortical collecting duct. In the cortical collecting duct, when the hormone aldosterone acts, yes, this is that renin-angiotensin-aldosterone system. When aldosterone acts, it will produce a channel that is known as INI-CET channel. From this, 1 to 2% of sodium is reabsorbed. So what did I tell you? 67% in the PCT, 25% in the TAL, thick ascending limb of Henle, next 5% in the DCT via sodium chloride symporter, and 1 to 2% by the INI-CET channels. So this is the basic anatomy and physiology. If you understood this much, the diuretics are going to be really easy. Now, what is the first class of the diuretics? These are known as carbonic anhydrase inhibitors. Now, what will these carbonic anhydrase inhibitors do? They will indirectly block this sodium hydrogen antiporter by blocking the carbonic anhydrase enzyme. That is why they are known as carbonic anhydrase inhibitors. Yes. Now, what will happen when you block this sodium hydrogen antiporter? Sodium reabsorption is decreased. When sodium is not reabsorbing, the sodium will be lost through the tubules into the urine. Now, wherever sodium goes, water follows. So there will be loss of sodium and water. This is what is known as diuresis. So what is the mechanism of any diuretic? So if you block any of the sodium channel reabsorption, what would happen? The sodium will go outside, along with the sodium, water will go outside. This is what is known as diuresis. So did you understand the mechanism of diuretics now? First class is carbonic anhydrase inhibitors. This will block the carbonic anhydrase enzyme, and this will in turn block this sodium hydrogen antiporter. The sodium is not reabsorbed. This will be going out in the urine. This is what is the diuretic effect that we are talking about. Now, what are some of the examples of carbonic anhydrase inhibitors? I want you to remember one thing, that is acetazolamide. acetazolamide. Now this is drug of choice in acute mountain sickness. This is drug of choice in acute mountain sickness. We've seen this MCQ before. Do you remember? If there is motion sickness, it is scopolamine, but if it is acute mountain sickness on the top of the mountain, that is acetazolamide. Now, coming to the next class of drugs, if we block sodium potassium 2 chloride, what will happen? Sodium will be lost, water will be lost. So these are also diuretics. These are loop diuretics. Why? Because it is acting on loop of Henle. Yes, that's all. Now, what are the examples of this? Torsemide, furosemide, and ethacrynic acid. Now, where can we use this loop diuretics? Loop diuretics are drug of choice in acute pulmonary edema. Now, they can also increase the GFR. So you can use it in patients who are having renal problems. Yes, because it is increasing the GFR. This is what. Now, in acute pulmonary edema, which loop diuretic would you prefer? That is IV furosemide. This is what I want you to remember from loop diuretics. So first class is carbonic anhydrase. They are acting on the carbonic anhydrase enzyme. Second one is loop diuretics. They are acting on sodium potassium 2 chloride channel in the thal. Now coming to the third class of drugs, these are thiazides. What will thiazide diuretics do? Pretty simple. This will block this sodium chloride importer. So the sodium is excreted outside along with the water. These are diuretics as well. So thiazide diuretics, easiest ones. How can you remember this? They have a name thiazide in their name. Chlorthiazide, chlorthalidone. We have one more, that is metolazone. Now, where is this metolazone used? Whenever in a patient the GFR is less, I told you we can use loop diuretics. If we are using loop diuretics and if the loop diuretics are not working, and even when the GFR is less than 40 and loop diuretics are not working, you can use metolazone. All the other drugs, they can be used in hypertension. This is about the thiazide diuretics. Now, coming to the fourth class of drugs, fourth class are potassium-sparing diuretics. Now, how will they act? Pretty simple. I told you it has to block this sodium channel. You can block this sodium channel via two ways. I told you these ENaC channels are coming only when aldosterone is acting. So you can block this aldosterone. They are known as aldosterone antagonist, or you can directly block this ENaC channels. They are known as ENaC channel blockers. Now, what is this aldosterone antagonist? It is pretty popular. It is spironolactone. What about these ENaC channel blockers? These are amiloride and triamterene. That's all. These are the four classes of drugs that we have studied: carbonic anhydrase inhibitors, loop diuretics, thiazide diuretics, and potassium sparing diuretics. Now, what I want you to remember in this, I want you to remember about the acute mountain sickness, about acute pulmonary edema, and then about the hypertension. These are the main uses. Now coming to the spironolactone, we'll study it in several chapters of CVS. Along with this, I also want you to remember it can be used wherever the aldosterone levels are high. This is known as primary aldosteronism, wherever aldosterone levels are high. Now, amiloride can be used in something known as Liddle syndrome. What is Liddle syndrome? You study this in hypertension. Liddle syndrome is gain of function mutation of ENaC channels. That means ENaC channels will keep on working. Doesn't matter if there is aldosterone or not. That is why we are giving amiloride in Liddle syndrome. That's all. Now, if you understood this much, what else you want to remember? You just have to remember the side effects of all of these. For this, I made a table which you can see here. So you can see this table. This is the revision table for entire diuretics. You can see here first class I have written as carbonic anhydrase. enzyme inhibitors. It is working on which part? It is working on the PCT. This itself is an MCQ. Whatever I am going to tell you, these are MCQs, PYQs and PYTs in all of these exams. Okay. So it acts on proximal convoluted tubule. It blocks the carbonic anhydrase enzyme. Now it will in turn block the sodium hydrogen antiporter. So if it is blocking the sodium and hydrogen, what will happen? Sodium is lost. So there is a decrease in sodium. Along with this, almost all of the diuretics will lose potassium. So it is losing potassium, and it also loses bicarbonate. Because of this, it is causing something known as metabolic acidosis. And it will also cause hyperammonemia. So it is contraindicated in liver failure. Or liver cirrhosis. This is about the carbonic anhydrase inhibitors. Now coming to the loop diuretics, where are they going to act? They are acting on the TAL. Now which channel is it blocking? Sodium potassium 2-chloride channel. Now when this sodium potassium 2-chloride channel is blocked, all of these ions are lost. Now easy way to remember is loops will lose everything. It will lose almost all of the ions. So if you see here, it is losing sodium, it is losing potassium, it is also losing H+, it will also lose magnesium and calcium as well. Now if you see here, because of loss of H+, it will cause metabolic alkalosis, and then there is loss of potassium, so it is hypokalemic. Now coming to the thiazides, where are they going to act? It will act on DCT. Which part of DCT? This has been asked in the exam. Before. It is early DCT. Now which channel is it blocking? It is blocking the sodium chloride importer. It also causes loss of sodium, so sodium is decreased, and it will also almost lose all of the ions. Except for one. It will also lose everything except calcium. It will increase the calcium in the body. So it will lose potassium, okay, it will lose H+, okay, it will also lose magnesium, but calcium is increased. So it will cause hypercalcemia. So it can be used in conditions where we want to increase the calcium. So these are drug of choice in hypertension with osteoporosis. Now it is also causing metabolic alkalosis because H+ is lost, and there is also loss of potassium, so it is also causing hypokalemic metabolic alkalosis. Did you understand this much? Now coming to the last one, that is potassium sparing. Where is it acting? It is acting on the cortical collecting duct. Now there are two classes. One is aldosterone antagonist, okay. The second one is ENaC blockers. This is what it is written here. It also loses the sodium, but these are potassium sparing. So what will happen to potassium? Potassium will increase and H+ will increase. In the classes I told you why this potassium and H+ will increase. Yes, whenever ENaC is activated, potassium and H+ will be lost because we are blocking this. Opposite will happen, that will increase the K+ and H+. This is the channel where potassium and H+ are lost whenever sodium is reabsorbed. If you block this, they will not come outside, they will stay in the body and they will increase. Yes, so I have told you all the concepts in the class. For now we are just revising. So what is happening here? It is causing hyperkalemic because potassium is increased, hyperkalemic metabolic acidosis. This is what I want you to understand. Why? It is given in the name itself. These are potassium sparing. Almost all the diuretics will lose potassium except for the potassium sparing diuretics. So I want you to remember it this way. There are four important classes: carbonic anhydrase, loops, thiazides and potassium sparing. All these three will lose potassium. Only thing that is increasing potassium is last one, potassium sparing. This much you got. Now first and the last one will cause metabolic acidosis. The middle two will cause metabolic alkalosis. This is an easy question. If they ask you which drug will cause metabolic acidosis, you know which one. But if they ask you which drug will cause hyperkalemic metabolic acidosis, I told you these two will cause metabolic acidosis, and this is potassium sparing. So this is hyperkalemic metabolic acidosis. These are potassium sparing diuretics. If they ask you hypokalemic metabolic acidosis, carbonic anhydrase inhibitors, that's all. Now, spironolactone, this will block the testosterone receptors as well, so it will cause gynecomastia and impotence. In the females, it might cause menstrual irregularities. Now, coming to the last class of drugs, this is our osmotic diuretics. Osmotic diuretics can act on almost all parts of the nephron, okay, but it acts mainly on this part. Which part is this? This is descending limb of Henle. This is where osmotic diuretics are working. It is given in the name, it is causing osmosis. So what will happen? It will pull out all the water into the tubule and the water is lost. This is what is osmotic diuretic doing. Okay, good. You can see here it is working on descending limb of Henle. It is blocking H2O absorption. Okay, now electrolyte abnormalities, anything can happen. Potassium might increase, potassium might decrease, H plus might increase, H plus might decrease. So we are not going to talk about this. But what is most important here, the example of this is mannitol. Osmotic diuretics, please remember this, very important, it is mannitol. Mannitol is drug of choice. Mannitol is drug of choice in cerebral edema as well as acute congestive glaucoma. Acute congestive glaucoma. I told you closed angle glaucoma, what is the drug of choice? CA, it is pilocarpine. Now, if a person is having a acute emergency episode of closed angle glaucoma, first you have to give IV mannitol. Once the IOP, intraocular pressure, is reduced, then you will give pilocarpine. So that's all about the diuretics. All the diuretics, you can study it in this one small table. Did you get it? Good. Now, we have talked about almost all of these parts, but we forgot about the medullary collecting duct. Yes, how can we forget this? We did not forget this. What will happen here? A hormone called ADH acts here. ADH is also known as vasopressin. ADH means anti-diuretic hormone. This will reabsorb water. This is what is happening in medullary collecting duct. So there is a receptor that is known as V2 receptor. ADH will act on V2 receptor and it will cause water reabsorption in a normal person. Let us suppose a person is not secreting ADH. Then can ADH act on V2? Can it reabsorb water? No. If it cannot reabsorb water, water will be lost, and that is what is known as polyuria. Yes, this is what you see in a patient with diabetes insipidus. Did you understand? So diabetes insipidus is nothing but ADH not working. Okay. If ADH is not released from the brain, we call it central diabetes insipidus. Now, let us suppose if ADH is already released from the brain, but it is not able to act on the receptor, then we call it nephrogenic diabetes insipidus. That's all. Nephrogenic diabetes insipidus. So you understood what is diabetes insipidus as well. Now, how do you treat this? In central diabetes insipidus, we don't have ADH. So you give ADH. Now, there is a drug called desmopressin. It acts mainly on V2 receptor. So desmopressin is the drug of choice in central diabetes insipidus. So in central diabetes insipidus, what is happening? There is no ADH itself. So we will give ADH from outside. So there is a drug called desmopressin, which works exclusively on V2 receptors. V2 receptors are present in several areas, but when it acts on the V2 receptor of medullary collecting duct, it will cause reabsorption of water. So it is used in central diabetes insipidus. It can also be used in nocturnal enuresis. What do you mean by nocturnal enuresis? That means a kid urinates at the night time. So if the kid is urinating at the night time, if you give desmopressin, what will happen? The water will be reabsorbed and urine formation will be decreased. That is why it is also drug of choice in nocturnal enuresis. Now, if you understood this much, we will see about the vasopressin related drugs. Recombinant vasopressins, we have two, terlipressin and desmopressin. Terlipressin acts mainly on V1 receptor. V1 receptor is present on blood vessels. It will cause what? Vasoconstriction. So that is why it is drug of choice for esophageal variceal bleeding. Why? What do you mean by varices? That is vasodilation. If you cause vasoconstriction, can you decrease this bleeding? Yes. That is why we give terlipressin, because it acts mainly on V1 receptor. Next is desmopressin. It acts mainly on V2 receptor. That is why it is drug of choice for central diabetes insipidus, nocturnal enuresis, and it is also drug of choice for von Willebrand disease and hemophilia A. Von Willebrand disease and hemophilia A. This is what I want you to remember. Okay. Now, the most important thing in psychiatry is they might ask you what is the treatment of choice for nocturnal enuresis. Drug of choice is desmopressin, but treatment of choice is bed alarm therapy. Bed alarm therapy. Did you understand? Bed alarm therapy. Now, you have seen the ADH analogs. What about ADH antagonist or vasopressin antagonist? If it blocks the V2 receptor, what might happen? Now, I've told you about a condition that is diabetes insipidus. Let us suppose if there is too much of ADH, what might happen? That is what is known as SIADH. Lot of water is being reabsorbed. Now, what can you do? You cannot decrease the ADH level, but you can block the receptor that it is working on. That is what is vasopressin antagonist. These are known as VAPTANs. VAPTANs means vasopressin antagonist. Vasopressin antagonist. Tolvaptan, Mozavaptan, Conivaptan. Conivaptan is IV. The other ones are oral. These can be used in SIADH. This finishes your renal system. Now, before going, I just want you to remember three things. This one you already know. Central diabetes insipidus. What is the drug of choice? That is desmopressin. Okay. Now, next. Nephrogenic diabetes insipidus. What is the drug of choice? The drug of choice is thiazide diuretic. Now, lithium can also induce diabetes insipidus. Lithium induced diabetes insipidus. What is the drug of choice? Amiloride. Amiloride is also drug of choice in Liddle syndrome, if you remember. Now, how can you remember all of this? Central desmopressin, okay, you know. Lithium induced. You can see here amiloride, LO, yes, lithium. So, Li, lithium. So, this is how you can remember. Now, coming to nephrogenic diabetes insipidus, where is the receptor present? It is present on the tubules, collecting ducts. Yes, it is present on collecting duct, but try to remember it is present on tubes. Isn't it? Collecting duct means tubes. So, T for T, thiazides. This is how you can remember all the three diabetes insipidus and their drugs that can be used respectively. Now, if you understood this much, again, revise 1 minute, try to revise the entire diuretics and also see the vasopressin related drugs. Next, we will start with the general pharmacology. Okay. So, I hope you have revised the renal system.